Hello, everybody. My name is Nicholas Lim. I'm the Intensive Care Fellow in University Hospital Galway on the west coast of Ireland. Thank you, Dr. Hampton, for inviting me to speak at this Cracow Pocus conference. I was in Cracow about 3 years ago with my girlfriend, and we were really impressed with the city. It's such a beautiful city for walking in. There's so many things to see and do. And I hope to be back in Cracow in the next little while once everything settles down. So Kasha's tasked me with speaking about soft tissue applications in the ED. So let's get on with it. This is going to be case-based. So these are actually cases that I actually remember vividly when I'm in the emergency department. So first case. So don't know how popular rugby is in Poland, but it is almost religion here in the Republic of Ireland. So we have a 17-year-old front row rugby player on the way in from the field. The coach and the physios have called it in, and they've said that this guy tackled someone really badly, and he's got very limited movement in his shoulder. The paramedics have him. His vitals are normal, normal blood pressure, normal SATs. They are not worried about any other injury except for what's happened to his left shoulder. He is huge. He is a big guy, and he's arrived to your department in the middle of peak hours. If we went down before I learned Pocus, I suppose we would have booked an X-ray for him. I examined him and then booked an X-ray for him. And in reality, a lot of us work in emergency departments where there's barely any standing room for the staff, much less for patients. So he goes down this algorithm that I would call the standard, normal, ordinary algorithm. Patient you suspect a dislocated shoulder, you examine them. The examination, depending on the body habitus of the patient, can be quite difficult. Depending on the anatomy, depending on the size of the patient, depending on how much body fat they have, this may or may not be conclusive. We are always taught to do an X-ray before. And if you remember back to the really busy emergency department, booking an X-ray, the time between booking an X-ray and for an X-ray actually happening can vary quite a bit. So in our case, because the department is so busy, the patient has gone off to X-ray, and it's not till about an hour and a half later before he comes back, and we've decided that, or we've diagnosed him with a dislocated shoulder, both on clinical exam and on your radiological study. So if you try non-sedation techniques, you may not be able to achieve complete muscle relaxation, and you may have to end up sedating this patient. Again, finding a space to do this safely can take quite a bit of time. So say we give it another half an hour. So an hour and a half for X-ray, half an hour for sedation. So that's about 2 hours. And then we try and relocate the shoulder. Okay, so again, remember the clinical examination. It may have been quite hard. It's quite hard to tell now whether the shoulder is in or not. We book another chest X-ray. Check X-ray. So again, we wait for the patient to wake up. That could take 20-30 minutes or maybe more depending on the agent that you've used. And then another probably about an hour before he gets his X-ray done. So if you can see, this whole process will probably take almost half the day if in a really bad, worst case scenario. Now, if you have a good reduction in all of that, great. But, on the off chance that the shoulder is not reduced, then you're kind of in a bit of a pickle, as I would say. You know, you may have to go back and go sedate him, try and relocate it, let him wake up again, and do a check X-ray. You know, hope again that there is a good reduction. However, if there's not a good reduction, then you know you're going to go back and repeat this. So this is kind of like what I would consider a spiral of time. You know, so you're really there's a lot of waste of time and waste of resources here. Kind of like the cat looking at the toilet flushing there. You know, it's not. You know, it's not great for patient experience, and for the doctor, it's probably even worse. Now, if we were instead to use ultrasound and incorporate this into our pathway, so using ultrasound for shoulder relocations is any studies that have been done have shown that the sensitivity is up to 100%. And up to 100% specificity as well. So it's a really good test for dislocated shoulders. So what does a dislocation look like? So you put the probe, you can use a linear probe if the patient is slim enough. A lot of the times I would use a curvilinear probe, especially for rugby players. There's quite a bit of muscle mass there, or some really large people with a high BMI. You may have to use the curvilinear probe. Have a look posteriorly, and this is what you should see. So let me just orientate you. This is the probe. Okay, this is skin on the posterior aspect. We are pushing our probe along the line of the scapular spine, because you can feel the scapular spine. It is palpable through skin. You put that across the shoulder joint. What you see here is the posterior aspect of the scapula. This is the glenoid labrum. This is where the shoulder should sit. This is the infraspinatus muscle. And then you can see if he has a dislocation, then he has the humeral head will be shifted forward. Okay, so the more posterior, the more into the far field you go, the more anterior it is to the body. So as you can see here, you have diagnosed a dislocated shoulder here. Now, so what happens then after that? So you can choose to sedate them, you know, and try and manipulate the shoulder back into place. You know, there are loads and loads of techniques, obviously, and I won't really go through them. But when you relocate that, then you can just put the probe on the shoulder again, and you can see now that, you know, everything lines up. So this is the glenoid labrum. This is the humeral head. You can see that it's well opposed. Now this is the infraspinatus muscle. And once you have this done, so this is one sedation. You just give him one dose of sedative medication. You reduce it, check it with the ultrasound, and you can be quite sure then that it is relocated. You know, obviously with your protocols in the hospital, you may still have to order an X-ray, a before and after X-ray, but at least you are absolutely sure that you don't have to repeat this process over and over and over again. This is how this protocol works. So dislocated shoulder, you do a clinical examination, you ultrasound them, okay? So you've diagnosed or ruled out shoulder dislocation. You reduce it with non-sedation or a sedation method. Then you re-ultrasound them. Now, if it hasn't gone in, you can always go back and ultrasound it again, reduce it while they're in the same cycle of sedation, and then repeat ad nauseum. Okay, so more ultrasound is always good. If you have the opportunity to do more ultrasound, that's great. But you can get where this is coming from. This, from here to here, you are probably looking at most an hour, if you count, you know, that you may not have relocated it successfully the first time. Okay, so huge difference in the patient experience. You know, certainly you're gonna really look very, 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 very slick with this. Okay, just like this this little cat here. Okay, so going on to the next case then. So this is the standard Polski Bachka. She is on her way to the market, and she has fallen over on her outstretched hand. This is what you get, so this is what we call a Chole fracture. Chole was a orthopedic surgeon based out of Dublin, actually, in the Republic of Ireland in the late 19th century. And he coined this phrase. So this is a Chole fracture, as you can see, is well displaced. For patient to relieve the pain and suffering and to hopefully ensure a good union, what you may want to do is you want to reduce this. So, we go back to this cycle again. So, you suspect a Chole fracture. It looks like a Chole fracture. You do a clinical examination, X-ray again. Okay, so again, variable amounts of time taken to do this. Sometimes I said if my patients are ambulatory, I tell them to walk down to the X-ray department and get an X-ray done. It may take them an hour to get an X-ray, and then instead of coming back, sometimes they decide to go for a coffee, which takes another hour. And by the time they come back, they are full of coffee, have had their croissant, and then we're considering whether we should sedate them or not on an unfasted belly. That is great. So we try to reduce the fracture then. And then again, we have to send them for a check X-ray, and hope that we have a good reduction. Again, if you leave a Chole fracture for any length of time, there's going to be a whole pile of swelling. Sometimes the reduction may not necessarily be as good as you think. So again, we repeat this again. So not a good reduction, goes back, and then cat is looking at the toilet bowl again. Okay, so this is not a good thing. So now, how do we look at fractures on the ultrasound? Literally, you just put the ultrasound probe, usually a high frequency probe, on where it hurts. Okay, it's as simple as that. It is so simple that with children with fractures, it is so easy. You just put it on and you show them the screen, and the child is distracted by the screen. And sometimes they even point out where the fracture is for you. That's the best. You don't even have to think. They can tell you immediately where that fracture is. So as you can see here, so this is the bony cortex. There is a disruption there, and there's a small hematoma here. Now, if you do hematoma blocks, you can use your ultrasound to guide you to inject the hematoma. So that's a valid target there. Again, if you have a fracture, as you can see here, I'm not too sure where this fracture is, but you can see here, this is the bony cortex, and there's obviously a break here. Again, there's a small hematoma here, another target for a hematoma block if you want to do it that way. Okay, now with our Polish babchka, so this is her Chole fracture on the X-ray or the ultrasound. As you can see, it's well displaced. We give her a bit of sedation, or we could do a nerve block on her, or we can do a hematoma block, and then we push-pull, and you can see now the bony cortex is aligned pretty well. The back slab goes on, and you can send her down for a chest X-ray. You don't have to wake her up. You don't have to, wait. The patient does not have to wait to have an X-ray done. This is a lot more streamlined. So looking at the protocol again, so fracture, clinical exam, do the ultrasound, sedate and reduce, or perform a nerve block and reduce. Repeat the ultrasound. If you have a good reduction, great. If not, you can always repeat. And as we said, lots and lots more ultrasound is better, and it looks really, really slick. Okay, so come to the end of my talk. So this is in conclusion. So you need to change your workflow. Okay, life is busy as it is already. Much more so now in emergency medicine. There are a lot of things there that are taking up your time. And you certainly do not want soft tissue injuries to certainly take up your whole day. I remember before ultrasound, spending a whole day with one patient trying to get their Chole fracture reduced properly. You know, and certainly with ultrasound, this has changed the way that I work. And again, you know, with fractures, the identifying fractures is really, really easy. Don't underestimate ultrasound. Children, it's so easy that children can ID the fractures for you and save you a whole pile of work. Okay, so just do it. Okay. Now, if you have any questions, this is my Twitter handle. You know, if you have any questions, you can direct message me on Twitter, or you can follow me on Twitter. So thank you very much for inviting me to Cracow Pocus. I hope you guys have a great conference, and hope to see you soon. Bye.